Right. So here's my approach, right? If I have a patient in the first line, previously untreated CLL patient, number one question is, do you see 17p deletion or p53 mutation? Yes or no? Okay. And then if I if there is any chance that chemotherapy would even be considered, then I would like to know what's the IGHV mutational status. Okay, now let's talk about somebody who has an intact p53 gene, so no mutation and no deletion. Your options are either ibrutinib or acalabrutinib. I put them together because pretty similar drugs, or a venetoclax-based therapy, right? Which one between ibrutinib and acalabrutinib? I think it's fair to say that acalabrutinib is just a better drug from the toxicity profile. Head-to-head studies are done in the relapse setting, and we'll learn more about it. But I think acalabrutinib overall, from the side effect profile, it's my preferred choice. So if I have to use a BTK inhibitor, that would be my choice. But really, the big question is, do you go with a BTK inhibitor or would you go with venetoclax and obinutuzumab as combo? I think the biggest factor is to talk to the patient and learn about their interest, their level of interest in having a time-limited therapy. So venetoclax, obinutuzumab is given for 1 year, and then you stop, and you may have the option of having patient off treatment for a long time. Now, it's not given for everybody, right? You may stop, and months later they have to go back on treatment. But looking at the data from the CLL14 study, the follow-up, if you achieve a good remission, which most of the patients achieve, like an MRD negative remission, you can potentially go without treatment for a long time. So that's great. So the bulk of discussion when I have a patient without 17p deletion or p53 mutation is, do you care if you're on a medication forever if you don't have major side effects? And if they say, you know what, I don't care. I take medication for diabetes, and I don't, I want something that I can start now. It's my friend's wedding a month from now. I want to just be ready for it. I don't have time to go through the ramp up that you need for venetoclax. Then, it can go on a drug like acalabrutinib. If, especially a younger patient who cares about or is very passionate about having a treatment for a year or so and then stop, then you go with venetoclax. So that's the main discussion. Then you also look at the side effects and what medical conditions patients have, right? If I have somebody in front of me with significant uncontrolled hypertension to begin with, if they have atrial fibrillation, if they have bleeding issues or taking multiple like blood thinners and antiplatelet drugs, then maybe a BTK inhibitor is not a great option for them. So that would be a patient that I would consider venetoclax-based therapy. On the other hand, if I have somebody with super abnormal kidney function, or they can't really, they don't have the means or interest of coming to clinic once a week for 1 or 2 months, depending on whether or not you use a debulking strategy, and they, and then maybe for those patients you want to go. So many factors. I would usually put them in 3 categories. Disease or specific factors, and that goes with the molecular profile, and I'll get to the p53 abnormal patients. So disease or specific factors, patient specific factors, so that's the age, that's the comorbidity, what side effects you expect. And then, I would add a social, really, if I have somebody who lives by himself, I have a patient who doesn't have a car and he can't drive, can I safely get him on a venetoclax ramp up that requires like long visits for weeks? I'm a big fan of venetoclax because I think time-limited therapy is important, but these are all factors that you need to discuss. Just to finish the topic here, I kind of discussed the p53 normal situation. What if somebody has a mutated mutated p53 or a deleted 17p chromosome? So for those patients, I think the best data is from BTK inhibitors. For those patients, my approach is to go with ibrutinib or acalabrutinib. And then my second choice would be venetoclax-based therapy. And those are high-risk patients, and that's kind of bulk of, one of our interests, my interest, and what we do here at the Hutch is really having a program for high-risk CLL, and that includes all these novel agents, some newer ones in clinical trials, and using really cellular therapy, including CAR T cell therapy and transplant for those selected